Start my afternoon report. Can everyone hear me?
Yeah, just press on the screen. Yeah.
Okay, got it. So this is a case of an 85-year-old male with history of mechanical aortic valve replacement on warfarin, polysubstance abuse, notably cocaine and alcohol, with a recent admission to Morningside for pneumonia, which was thought to be secondary to aspiration versus rhinovirus, and his course was complicated by AKI. He's coming into the Ryan Center Clinic at 97th Street for an INR check. He reports feeling well, no complaints. Even though it's an INR check appointment, I did some chart review and looks like the patient was seen 1 week ago for a hospital discharge follow-up. And besides the INR check, repeat labs were also ordered. So just a basic review of this patient. He has the past medical history of mechanical aortic valve replacement. He's on warfarin, but does have history of labile INRs, labile INRs. For his social history, he uses cocaine. Unclear how often. He says he hadn't used it since the last time he was in the hospital, but I think he probably uses it on and off socially. He says he drinks a few 40-ounce beers a day. Lives alone at home and performs all his ADLs, even though he's 85 years old. He doesn't have any family history. He's only on amlodipine 5 and warfarin daily. It has no allergies. On review of systems, he pretty much says he's feeling well. He's walking around. He hasn't had any changes in like urinary habits, no hematuria, no frothy urine, but since his hospital discharge, but he does say that he doesn't eat or drink that much, but it's been chronic. He says sometimes he has difficulty swallowing food or difficulty drinking a lot, but it hasn't changed since before the hospitalization. No changes in bowel habits, no lower extremity swelling, no chest pain, shortness of breath, anything like that. So on my exam, he's normotensive, his heart rate is fine. He's thin, BMI is 22. He does appear thin, but well. He's conversant. He appears much younger than 85. He's walking, talking, very with it. He doesn't have any rashes on his skin. For his heart exam, I can hear the systolic murmur with a click, but it's regular rate and rhythm. His lungs are clear. His abdomen is non-tender and soft, and he has no lower extremity edema. So I follow up on his labs, and he was discharged from the hospital. His creatinine was 1.59, and today in our clinic, it's 2.28 with a BUN of 31, GFR of 29, a slightly elevated AST at 51, and an INR of 2.3. So we saw this creatinine bump, which is over 1.5 times what it was when he was discharged. So we repeated it, and it was exactly the same. We got a UA, just showed 3+ blood with over 60 red blood cells, leukocyte esterase, negative nitrites, no white blood cells, no protein, no casts. A protein creatinine ratio was 0.2, urine sodium was 50. We didn't get, the creatinine was ordered, urine creatinine was ordered but not completed, and we were thinking maybe there was an obstruction, so we got a renal bladder ultrasound urgently, and it had no obstruction, and no hydro, and everything looked fine on the kidneys besides maybe chronic renal disease. We asked for an urgent renal appointment, but the closest one they could schedule was in 6 months. So, I mean, on this workup, we have a new AKI and some unrevealing ultrasound with an unrevealing, well, besides some microscopic hematuria, this workup has been pretty unremarkable for this AKI. I was wondering if anyone could tell me would you send this person to the emergency room? Would you not send them to the emergency room for a further workup or an expedited workup? Does anyone have any questions?
Very quickly, does anybody have any questions about the history, about the exam? Or what are your thoughts about when you see this patient in clinic? Carlos asks, is he a smoker?
No, not a smoker.
Ariella asks about CVA tenderness.
No CVA tenderness.
Has he developed any ascites or abdominal pain?
So we don't have an abdominal ultrasound, but he has no abdominal pain and his exam is benign. He doesn't have any distension.
Dr. Singh wants to see the med list again.
It's just amlodipine and warfarin. Or do you want me to scroll back to it, or?
That's okay, if it's just close to you.
Yeah.
Carlos asks, does he have dysphagia or unclear?
It's unclear. Seems like chronic, like for years, he's just hasn't been eating that much. Like he says that when he drinks a lot of water, sometimes it comes up, but he's never been like diagnosed with dysphagia, no.
And then Fatma's asking more about the aortic valve replacement. Do we know when it was done?
It was done in the early 2000s, but he hasn't had any issues with it and has followed up with his cardiologist.
Elizabeth, can we go back one more time, look at the BUN creat ratio, and then you said the only antihypertensive is the calcium channel blocker.
Yeah, so
BUN.
yeah, so he's just on the amlodipine and the warfarin. His creatinine is 2.28 and BUN is 31.
Okay.
Yeah,
and the vitals you had in the clinic, what is his heart rate and blood pressure running?
Yeah, blood pressure 119/77, heart rate 99.
Okay. Is he orthostatic?
They weren't checked in the clinic.
But on exam, did he have any other signs of being?
No, I mean, when he stood up, he wasn't dizzy. He had no issues walking around.
Did his skin turgor look, he looked particularly dry? Did he,
Yeah, I think he looked like maybe a little bit dry in his oral mucosa, but other than that, no.
Right. So it is let's vote. Who votes he should go to the ED? Or you should send him to the ED? Nobody?
I guess what are you hoping that they do in the ED that you can't do outpatients?
Yeah, so pretty much he got an ultrasound, he got UA that showed just microscopic hematuria. He qualifies for an AKI, but and he doesn't have a nephrology appointment for 6 months. So I guess, we get patients all the time who come into the ED for just an AKI, get admitted. So I guess the question is when do you send them, or like,
So
like
that would depend on what you think is happening, right? Do you have a differential right now? Does anybody want to comment on what they think could be likely?
Sorry.
All right, so they
he has heavy alcohol use, right?
Yeah, previous to his admission, he would drink like 40-ounce beers a day, every day, but not like liquor, but it's long-term beer. Yeah.
So could this be like early hepatorenal, just as a
I think hepatorenal is a bit of a stretch right now, because first of all, for hepatorenal, you need to have cirrhosis, and then stigmata of cirrhotic disease, and then once it progresses, hepatorenal is not an early manifestation of cirrhosis; it's usually a late manifestation. And if you don't have any stigmata of liver disease, I think hepatorenal is. And you think about more common things first, and you would work up outpatient and then repeat the labs, and then consider if you don't have it. If you don't have, the patient's creatinine is getting worse, you don't have a possible etiology, then you could think about other things. So, Fatma says, yeah, it can be prerenal in the setting of poor PO intake and possible dysphagia. Okay, all right. Fair differential. Let's move forward.
And I was going to say, if you don't think if you think that he can come back to the clinic the next day, and you can recheck his labs then maybe you can say, okay, we can avoid an emergency room visit. But if you don't think that would be possible for him, it would be very important to recheck his creatinine after he drinks more water.
Yeah, right. I mean, he is reliable to follow up. And we had, he came in the week prior to check those labs. So he would be amenable to follow up, but yeah, so I can continue here. So Pretty much he.
I have a quick question, just because I don't do clinic anymore. Is there a way to check like urine microscopy and look at red cell morphology? Like these red cells that we're seeing in the urine, can they be characterized?
I'm actually not sure.
You were in the clinic a long time ago, Dr. Singh.
Decade. No.
I would say that also depends on the clinic, right? So some of our Ryan centers, I don't think we have the capabilities of doing microscopy. But maybe I don't know what's the situation over here at the faculty practices. But certainly at Ryan, where we saw this patient, I don't think we can do a spin and a.
Pretty much you can't keep microscopes any place anymore because you can't keep them clean. So
All right, let's go ahead.
Okay, so he adamantly refused to go to the emergency room because he said he was in the emergency room over 24 hours last time, and he would come again to follow up. He would try to drink water and repeat his labs. So he needed to come back anyway for an INR check after warfarin adjustment. So he came back and we repeated labs. And looks like his creatinine is even worse. Now it's 2.89 and an INR of over 8. So when these results came back, he was called and sent to the emergency room for expedited workup and for super therapeutic INR. So in the emergency room, he's very irritated that he's in the emergency room, and his exam is pretty much unchanged. His blood pressure is a little softer, 99/65. Otherwise, vitals are fine. His pulse was 97. CBC, hemoglobin 11, platelets 140, and BMP significant for creatinine of 2.89, potassium 4.7, BUN 52. AST is still elevated at 57, and now his T-billy is slightly elevated at 1.6 with the direct billy of 1.1. His INR is 6.7. He's found to be incidentally COVID positive. And then in further chart review, it's revealed that he does have an undifferentiated connective tissue disorder. He had a positive ANA and ANCA in 2016, but like wasn't worked up and wasn't seen by room. Oh, so I guess we're supposed to.
The setting of time,
Yeah, it's fine. Okay, so for our problem representation, this is an elderly male with history of mechanical aortic valve replacement, polysubstance use, questionable undifferentiated connective tissue disease with a recent admission for pneumonia complicated by AKI, now presenting from outpatient clinic with worsening AKI and super therapeutic INR. So any suggestion on further workup, like what should we order if you are seeing this patient and admitting him to a medicine team?
So I'll just take this opportunity. Like we have, a differential. We know that this patient has some kind of renal dysfunction. So what are the tools you use to assess for renal disease? So for every organ system, you'll have a different set of tools, right? So for cardiology, you have EKG, troponin, echo, and then maybe angiography. For GI, you have endoscopy, colonoscopy, stool, fecal occult, things like that. And then for neurology, you have LP, MRI, CT, imaging. So for renal disease, let's talk about our buckets of tools. What's the first tool you can think of for evaluating renal disease?
So we need urine lights.
That's one category, all right? So urine serologies. Can you tell me, let's be specific, which ones?
So it usually would take like urine sodium or urine creatinine to calculate the phenom, but if the patient is on diuretics, we do fractional exertion of urea to see if it's like renal or pre-renal. Also, we need a UA with microscopy just to see if there's like plain, if there is like glomerulonephritis, if there is like signs of acute interstitial nephritis.
Let's just take it one at a time. So urine serologies, we talked about things to calculate FeNAF, FeUrea. So that's one better. Anything else along with urea creatinine? There's another thing which is used in urine protein to creatinine ratio, right? You want to see if this patient is proteinuric or not. So that's one bucket. That's urine chemistry. The second bucket you already said, so UA. What information does the UA give you? We're not talking about infections here, but we're talking about renal dysfunction. So what information do you get from a UA?
So like there is a cast if you have like ATN, you can have granular cast. If you have glomerulonephritis, you would have red blood cast with proteinuria, hematuria sometimes.
That's good. That's a third setting. That's urine microscopy. So that's not something which comes in every UA, right? You need to spin the sediment to get and look it under a microscope. But if you order a UA on Epic, you'll get a certain number of things, but you won't get all of that. So that's a third bucket of tools called urine microscopy. So that's very important. That's another tool you can use. But within the UA, you get a lot of things, right? Obviously you get the cells, WBCs. The things which are important in renal disease are protein. So you get protein and you get RBCs. Can anybody tell me what's the difference between the protein you get in a UA and the protein you get from protein creatinine ratio? How are they? Yeah, Kiran gets it. UA is just albumin. When you get the protein 1+, 2+, 3+ in a UA, that is just quantifying albumin. So if there is a non-albumin protein in the urine, like a globulin in a paraproteinemia, it will be 0. So if you have a large differential between the level of protein in the UA and the level of protein when you get from quantifying it, that usually tells you that it's a non-albumin protein. Let's see anything else in the chat. So you get blood. You can you get 1+, 2+, 3+ blood in the UA. Can anybody tell me what is it looking for? Is it looking for RBCs or is it something else? Can sometimes there be a can you get different information from the UA and from microscopy?
Eosinophilia and acute interstitial nephritis, like urine eosinophils.
That's I'm referring to like when you get blood positive in the UA, but you don't see any RBCs. Yeah.
Myoglobin, yeah.
Exactly. Yeah. So that's looking for pigment. That's not actually looking for cells. And then cells is something you will see on microscopy. So great. That's one. You get urine chemistries, urine analysis. We talked about microscopy. So we have 3 tools. Any other tools we use for these patients? Lights, right? Blood chemistries, BMP. That's an important tool. urine creatinine ratio, like trending creatinine, that's an important tool. Electrolytes. So serum chemistry is another bucket of tools. Good, Ariella, imaging. What imaging modalities do you use in these patients?
Ultrasound.
Ultrasound first.
Great, ultrasound. Bladder scanning, that's also very important in these cases, right? Because if you have a post-void residual, that will change your differential for post-renal obstructions, right? And then any more, if when you're talking about glomerular diseases, is there anything else in the blood you want to check?
There is a lot of stuff like it's based on our suspicion. It's like vasculitis versus, exactly. I mean, vasculitis versus like what's causing it, Hep C, Hep B, HIV.
Yeah. So that I put that into one bucket of serologies, right? So that will have Hep serologies, that will have antibodies, all of those things, that $1 million workup we sent for glomerular disease. So that's another tool. And then we talked about imaging, and then there's one other, the final boss of tools, which we use very sparingly. Biopsy, that's right. So these are the tools we use. These are the things which, you don't use all of them for all cases, but you should know what tools you have when you're, evaluating a disease, and then use them according to what your differential is. All right, let's go ahead.
Okay, so for further workup, I think because he had the positive ANA and INCA in the past, we kind of did all the serologies all together. He also had the hematuria. So in regard to the UA with microscopy, he had large blood, 25 red blood cells, but no dysmorphic red blood cells, no casts, no protein, and Luke esterase and nitrites were negative. For his urine sodium, it was 40, and the FeNA was 0.8%. A repeat renal bladder ultrasound was done, and it pretty much showed the same as prior with medical renal disease. The urine albumin creatinine ratio was normal. Urine protein creatinine ratio was also normal. AST still elevated at 57. Albumin was low at 2.4. T-Billy, the same, elevated 1.6, and direct bilirubin 1.1. In regard to his serologies, his ANA was positive. Titer was 1 to 320. His myeloperoxidase, anti-myeloperoxidase antibodies are also negative, are also positive and elevated at 23. His P-ANCA was elevated. C3 was low and C4 was normal. His rheumatoid factor was elevated at 24, and he was also found to be Hep C antibody positive with an RNA, with a viral load RNA of 249,000. His cryoglobulin was pending, but the rest of the workup was negative. SPEP, UPEP showed like IgM lambda and IgG lambda, but faint and wasn't impressive. Serum free kappa lambda ratio is also on like 1.13, but it's normal. So the new problem representation, elderly male, history of AVR on warfarin, polysubstance use, questionable connective tissue disease, recent admission for pneumonia complicated by AKI, presenting from outpatient clinic with worsening AKI and supratherapeutic INR, found to have microscopic hematuria with no proteinuria or casts, chronic Hep C with viremia, positive ANA, P-ANCA, elevated myeloperoxidase antibodies, low C3, and elevated rheumatoid factor. So I guess since we're limited on time, the differential diagnosis, as we kind of talked about with ONGOD, you know, it could be pre-renal given like his poor PO intake, and but however, his like urine lights, his FeNA was in line with a pre-renal. However, like his urine sodium was slightly elevated at 50 on outpatient, 40 on inpatient. So questionable pre-renal. His P-ANCA was positive, although he doesn't have any proteinuria or systemic symptoms. So rheumatology said that this is less likely on our differential. It could also be lupus nephritis. However, his double-stranded DNA was negative and anti-Smith was negative. Could be hepatitis C related myeloproliferative GN, but again, no protein in the urine. It could be cryoglobulinemia from his Hep C or COVID associated nephropathy. Also anticoagulant or warfarin related nephropathy. So we have a lot of differentials here. Does anyone have anything to add or questions? Oh, sorry. No, I guess. Okay, so also on the differential is just worsening of chronic renal disease in the setting of long-term cocaine use and hypertension. Although it's a very acute change, so it's questionable. So in regard to his hospital course, so he got, if it was pre-renal, he got a fluid challenge. His creatinine did not improve, renal function did not improve, so less likely to be pre-renal in this situation. His warfarin was discontinued because they thought maybe it was warfarin associated nephropathy because of the hematuria. He was started on a heparin drip. Creatinine plateaued at 2.8. His cryoglobulin came back negative. However, due to his like rheumatologic workup, also his newly diagnosed Hep C, the plan was to do a biopsy. But since he was diagnosed with COVID, and although he was asymptomatic, they deferred the biopsy for outpatient. His creatinine stabilized, and his heparin drip was transitioned to warfarin. He was discharged with the plan for outpatient biopsy if the creatinine didn't improve, or if the creatinine didn't improve, pretty much, he was gonna be planned for an outpatient biopsy.
Liz, can I ask you a quick question?
Yeah, sure.
Was there a theory as to why his INR jumped so quickly?
So that's the thing. There was kind of he was known to have like a labile INR, but there wasn't really a theory. They're saying maybe if he wasn't eating as much, maybe his like the vitamin, he wasn't getting enough vitamin K. But it was just we were constantly changing his warfarin dose. But hematology didn't comment on why he had such a labile INR. No. Any other questions before I move on?
No, thank you.
So he was discharged to Ryan Center once again, and we got a repeat BMP. Showed a potassium this time of 6.7 with a creatinine now of 4. It had plateaued to 2.8 on discharge within a week. So looks like it's worsening. His BUN was 39, GFR 13, and INR is now also still labile and greater than 8. UA still has large blood. Now it has, the protein was positive at 30, but still no casts. So he was readmitted to the hospital, and this time he got his renal biopsy, which showed focal global glomerulosclerosis, focal endocapillary proliferation and mesangial expansion, moderate arteriosclerosis, and severe parenchymal scarring. However, all of the findings were more consistent with those of chronic renal disease, such as like hypertension and arteriosclerosis. There were no crescents, no like cryoglobulin thrombi. There were some segmental endocapillary proliferation and some red blood cell casts, but the immunofluorescence and the electron microscopy studies were both negative for immune complex deposition. He did have a strange finding of enlarged mitochondria with a disarray of cristae, but it's unclear what the significance of that is. So not very clear on what the cause of the AKI was. Renal saw him again outpatient. They don't know exactly what caused the AKI, but since there was nothing on the biopsy to show anything that was reversible or treatable, there was nothing further to do. Maybe because of his age at 85, the biopsy was obscured by the severe parenchymal scarring, or the biopsy just didn't catch exactly what was happening. But it pretty much didn't, like it was negative for vasculitis or active glomerulonephritis. So I guess the final diagnosis is AKI of unclear etiology and CKD stage 5. So I know we are running short on time. It's 4:50, but just a brief review. So when you're getting your medicine consults and you're getting consulted for AKIs and the creatinine is not really elevated, it's good to know these definitions. So AKI is defined by an increase in creatinine by 0.3 within 48 hours, or 1.5 times the baseline within about 7 days, or the urine volume less than 0.5 milliliters per kilogram per hour for over 6 hours. So there are guidelines based that stage AKI. So 1.5 to 1.9 is stage 1, and over 2 it pretty much is stage 2. Over 2 times baseline, stage 2. Over 3 times baseline, stage 3, or you can look at urine output. If they're anuric, that's automatically a stage 3. And I just wanted to also add here the definition of CKD would be, evidence of kidney damage or reduced GFR, which has been present for 3 months or more. So in this case, I think it highlights the importance of, being in the outpatient environment and deciding when to expedite a workup, when to send a patient to the emergency room, when to get an urgent referral to a specialty. And it is recommended that a stage 2 or stage 3 AKI could be referred to the emergency room, or a stage 1 AKI, like this case, that's 1.5 times the baseline. Who don't have an have an unknown duration and unknown trajectory of the elevated creatinine. So if you're not really sure where the creatinine's going and it's just like it keeps going up, even if they're in stage 1, you could send them to the ED for expedited workup. Or if you think it's real pre-renal and the patient needs IV fluids, or if you're thinking they're septic or have a uncontrolled comorbid condition, that would also, you would usually send them for CHF exacerbation, ZKA, anything like that that could be related to a stage 1 AKI. Also, if you're just unable to get a renal bladder ultrasound or any type of ultrasound, or if you're unable to have good follow-up with the patient, you can also refer them to the emergency room. So in the interest of time, pre-renal, as we discussed earlier, like you can do urine lights, you can do a fluid challenge because it's made up of pretty much pre-renal is decreased renal perfusion. So they can be hypovolemic in the setting of decreased PO intake, hemorrhage, or GI losses. As Patrick mentioned, you can have hepatorenal or cardiorenal, which is these are hypervolemic states usually that result in just renal hypoperfusion. Intrinsic renal AKI, you want to look at, you can look at urine lights, but that might not always point you in the right direction based on the clinical picture. But there's intrinsic renal vascular disease that affect both small and large vessels. There's intrinsic glomerular disease, which are primary, like just a primary glomerular problem versus a secondary glomerular problem that's caused by systemic disease, drugs, or paraneoplastic syndromes. And this is where nephritic and nephrotic syndromes fall under. And nephritic, usually you have to have urine sediment with dysmorphic red blood cells or casts, which could be red blood cell casts or granular casts or white cell casts, anything that looks abnormal in the urine sediment, along with a variable range of proteinuria. And then there's intrinsic tubular and interstitial disease, which we mostly see in the hospital as ATN secondary to ischemia or nephrotoxins, acute interstitial nephritis or tumor lysis syndrome. And then we have the third major cause of AKI, which is postrenal. So those include prostatic disease, abdominal malignancy, or retroperitoneal fibrosis. So I always think of this system when working up a patient with AKI. And then for the workup, I think one of the most important things is the history, physical exam, volume status. You want to know what's going on with the patient, like if they've been eating, drinking, any changes in urine, any new medications. You could consider urine electrolytes because it could help to determine if what kind of AKI it is. You always want to review the medications, make sure nothing is nephrotoxic, or if they've received recent contrast for any studies. You definitely want to get the UA with microscopy to see what kind of sediment there is, if there's any casts. You can look at urine output, and as we said before, the renal bladder ultrasound to rule out an obstruction. And I think inpatient, one of the big things is when to order the big workup and what you think is going on, and do I just order the whole set of labs of the serologies or versus do I just wait and watch? And I think, three things would be if you suspect glomerular disease, if you're seeing glomerular hematuria with red cell casts or a lot of hematuria or proteinuria greater than 3.5 grams per day, you can order the workup, like the proteinuria workup. If the renal function is rapidly worsening and there's no known cause, or if there's a systemic disease that, like a rheumatologic disease that is usually associated with renal findings and you have bad AKI, I think it's fair to order it. On UpToDate, there are these really useful diagrams that I like to refer to, which kind of points you in the direction if you should order the whole set of labs or if where you should go with your workup. And so I think, we ended up here evaluate for glomerulonephritis because this patient did have abnormal hematuria, although it was negative for like casts or dysmorphic red blood cells. And it's 4:57. So I also love the up-to-date charts for looking at nephritic syndromes like glomerulonephritis and doing the workup. You can order C3, C4, ANA, ANCA, the whole workup, infectious workup, and ultimately with glomerulonephritis, you might need the biopsy to ultimately decide what the patient has. So additional take-home points for this patient. I think it's really important to order Hep C at least once, even in your elderly patients for screening. It's now recommended everyone 18 years or older to be screened for Hep C once. And if you do it at the Ryan Center, you'll be helping Chevry's QI project. You should always screen for drug use in the elderly. I think that a patient who's 85, you don't always expect them to be doing cocaine weekly, but it is a thing that happens, and it's important to ask in the history. Also, cocaine use can cause a positive ANA myeloperoxidase antibody. So just if you have an AKI and you're not thinking someone has a rheumatologic disease, they don't have any rashes, they don't have any other systemic symptoms, it's not like if you just have the positive ANA or MPO or ANCA in the setting of cocaine use, you don't have to always jump towards like a rheumatologic cause for that. Also, this case highlights the importance of close outpatient follow-up. Like luckily this 85-year-old patient was able to make it to Ryan Center multiple times to get repeat labs, and luckily the inpatient team scheduled Ryan Center appointments because he did not have a primary care doctor. But if it went on so long and he never came to the primary care to get his labs, he could be one of those patients that comes in obtunded with a creatinine of 7 and a potassium of 8. And it's very important to have close outpatient follow-up. And lastly, I think that this case highlights the challenges in providing care for patients during COVID. I think all the specialists were pushing for a biopsy for this patient to know what's going on before sending him home. But because of his asymptomatic COVID infection, it was deferred and deemed not to be an urgent biopsy. But I think in the hospital, we often see that we can't get the tests or procedures done for our patients that are tested positive for COVID, and how challenging it could be at times. So that's it. Sorry, I think it's right on 5 o'clock. Does anyone have any questions?
Right on time. Any questions? This was a great talk, great summary. All right. So the moral of the story for me was, sometimes even the biopsy can't tell you what's happening. All right. If no other thoughts, comments, we can call it a day and done.
Good.
All right.
Thank you. Thanks for listening.